So as you know, it is we're going to talk about psychological disorders and the hormone therapies, the beneficial effects on hormone therapies on psychiatric disease and psychological disorders. And we have a guest today, and we're going to start by interviewing the guest. And the guest is, let me see if I can go on with my presentation. The guest we have here is Ascanio. Ascanio, I'm going to stop sharing my screen so we can see you better. And Ascanio Polimeni is a good friend. He's one of the Italian pioneers of anti-aging medicine and hormone therapies. And he has something in common with me, is that he always plays the guinea pig for his treatments, meaning that if he starts a treatment, he will try it on himself. I think that's what you told me, Ascanio. And this is a golden rule I apply very often, is that when I start a treatment, I always try to know what it is. And the best way to know how it is to do the treatment. Ascanio, I know you will be afterwards in a hurry, so it is better that I interview you now. Ascanio, can you tell us something more about your work in neurosteroids? Neurosteroids are little compounds you have in the brain that are produced by the brain and that have psychological effects and also physical effects. Can you tell something more, especially about the psychological effects of neurosteroids and what they are exactly?
First, thanks to this invitation. Thanks to the people that are listening our discussion, our lecture. One of the main focus of interest is the effect in general of hormones on the brain. So we know that the nervous system is interacts with the immune system, with the endocrine system, and vice versa. So we need to see to this area in the same network. Of course, hormones, all hormones have effects on the neurotransmissions and are involved in a lot of disorders, psychological disorders, neurochemical disorders, or psychiatric disorders. So we know that the imbalancement of lots of hormones are closely related to depression, anxiety, and also schizophrenia, and so on. My interest is mainly focused on the effects of steroids that are the hormones that are produced from cholesterol by the adrenal glands and by gonads mainly, but also by the nervous system, the effect of steroids on the brain.
And can you tell something more about these effects? For example, I know that DHEA is neurosteroid. I know that pregnenolone is DHEA is neurosteroid. Can you tell some of the effects that it can do? An example, for example?
In general, the steroids exert two kinds of effects. Non-genomic effects, which means direct or indirect on neurotransmission, which means they improve the release of the production or inhibit the catabolization of neurotransmitters like serotonin, acetylcholine, dopamine, GABA, and so on. This depends also by the hormones. For example, the first hormone that we have studied also because it's the grandmother of steroids is the pregnenolone. Pregnenolone exerts a biphasic effect on GABA, that is the neurotransmitter of relaxing. The same transmitter, GABA, GABA. We know that benzodiazepines act on GABA, and some hormones can have an agonistic action on GABA, like progesterone, or the main one of the most important progesterone metabolites, that is allopregnanolone. Allopregnanolone is involved in a lot of anxiety disease.
Allopregnanolone derives from progesterone, I believe, huh?
Is a metabolite.
It converts into and delivers.
is a metabolite of progesterone. And the progesterone and these metabolites exert an agonistic effect on GABA, which means more relaxation. They improve, decrease, can have a positive effect on sleep and so on, like benzodiazepine. So in some kind of disease, when we check deficiencies of progesterone, we think, for example, in premenstrual syndrome or premenopause, when we have often deficiency of progesterone, instead of using benzodiazepines, we can use these hormones that act on relaxing.
So Ascanio, you would use progesterone also for men, so to have this relaxing effect?
Yes, we can. As you know, progesterone can be used also in men for anti-androgenic effect and could counteract the negative effect of dihydrotestosterone on prostate glands, but this is another area. But also in men, insomniac men, we can use safely progesterone, often combined in low doses with other supplements, not hormonal supplements that improve the sleep, like theanine, like glycine, melatonin, adenosine, and so on.
Yeah. So what would be a good dose of progesterone you would give to a man and a good dose for a woman, for example?
But for more women, depends also by the age. In menopause, we use 120 also. We know that one of the main compliance in menopause is insomnia. Insomnia, not necessarily related to hot flash, is one of the main problems in premenopause women. In this case, we use sublingual progesterone that, as you know, acts very fast, alone or combined with other supplements. The dose in these cases is around 100, 150 to 200 milligrams. For men, is much less, because around 25, 50 is okay.
And what is the doses, for example, of pregnenolone you would give for men and for women in general? What is the average dose you give?
But it depends by the different factor. I don't know the exact reason, but we saw a more effect in men of sleeping using the same doses. We need to know also the interaction of the hormones with the neurochemistry that is probably different in receptor sensitivity in women and men. So I prefer to use less doses in men, also if they are overweight, for example. There is not a reason. I saw more lethargy in men using the same doses of progesterone than in women.
Yes.
This is a personal experience. I don't know what is your personal experience about this possibility to use different doses, gender-dependent doses. Probably is a different the sensitivity of neurochemistry receptor.
Can you tell also, you are also an expert in what is called homeogenesis, or to have a better balance, in order that you have to have a certain stress. By having a short stress, people live longer and feel better. Can you tell more about this, or is intermittent fasting helping that? And
yes. This is another area of my special research, and we can find a connection between the hormonal treatment and the effect of the lifestyle changes on improving the aging process, and we know that low doses of stress exert a positive effect. This is the hormetic effect that is dose dependent. this is also for drugs. So if you use low doses for a drug, so you can have positive effects. Then you can have a lot of side effects increasing the doses. You say what said Paracelso a lot of years ago: dosis facit venum, which means that increases the dose of a drug or a supplement of a normal. We can have a lot of side effects. Hormesis means that low doses of stress. Hormesis comes from Greek hormao, which means stress, tension. Low doses of stress acts like vaccination, stimulates the cells to produce a lot of anti-inflammatory and antioxidant enzymes, not also, but the cells, in this case, especially the cells of the brain, of the muscle, under positive stress, so fasting, for example, of aerobic activity, release some neurotrophin. Among these, we are studying brain-derived neurotrophic factor. Brain-derived neurotrophic factor is a neurotrophin that is close to the relation to mood, improves mood, improves well-being, and except through the enhancement of dendrites overgrowth, the memory, of course, but brain-derived neurotrophic factor exerts also peripheral positive effect, improving sensitivity to leptin, to insulin, decreasing inflammation, that, as you know, is low-grade inflammation, is the mother of all disease.
You said also that DHEA can stimulate this brain-derived neurotrophic factor and mimic, in this sense, the short-term stress positively.
Yes, we know that DHEA, among the hormones that I prescribe, and I think also you, DHEA is one of the most quoted by the patients, especially women. I think that we have a great prescription of DHEA worldwide. This means that really it works, especially on well-being, on energy, on memory, especially in women, and especially in over 40 women in premenopause, menopause, and postmenopause period. We know that the DHEA exerts a lot of positive effects. You know everything. In the brain, exerts mainly effects on, as you know, dopamine, exerts also a GABA antagonistic action, stimulates NMDA, but now there are new studies that bind the administration of DHEA and the positive effect of DHEA with the effect that we find with fasting, with cold therapy, and physical activity, that are the main aspect of positive effect of hormesis on aging. This is the release of brain-derived neurotrophic factor. If you go on PubMed and write DHEA and brain-derived neurotrophic factor, you find very interesting study about the effect of DHEA. And especially if we combine DHEA with a change in our lifestyle, which means intermittent fasting, physical activity, but of these special aspects of hormesis on aging, we can speak, I think, next, because it is a very interesting area. So the administration of DHEA could exert its positive effect on aging also through the release of brain-derived neurotrophic factor that is actually considered worldwide one of the main neurotrophin involved in successful aging.
Very interesting. Is brain-derived neurotrophic factor available or not? Or you have to stimulate its release? Or is it also commercial?
We need to stimulate, because the brain-derived neurotrophic factor is easily catabolized. we don't have as a treatment, but we can stimulate through hormones. We can use with such, for example, homeopathic brain-derived neurotrophic factor is a nice medication, homeopathic BDNF, that is produced by famous German homeopathic brand. And in general, we can improve the release of BDNF using combining hormonal treatment and chronopathic or integrated hormetic strategy. This is a new area of research.
Now let's go over back to let's say more classical hormones like the female hormones and testosterone. What is your experience? Because I think you give all the hormones. What is your experience in treating the women with depressive feelings, men with depressive feelings with those six hormones? Do you have some examples where you were amazed, or you find they're actually
we can speak about two kinds of women that have the psychological compliance. The first group is young women, and we find great success in treating premenstrual syndrome in this lady with progesterone and metabolites of progesterone. That could be combined also with supplements that modulates serotonin release and production. I remember this is very important, that premenstrual syndrome that is recognized in UK, in USA, but not for example in Italy. Premenstrual syndrome is an atypical mood disorder that is inserted, of course, as actually non-identified mood disorder is inserted in the DSM-4, that is the Bible of psychiatry. The only drug that we can use, I'm speaking about drugs in this disease, in this particular disease of young women, are the SSRI, and like serotonin, paradoxin, sertraline, and so on. And we have a lot of studies, very intensive, that have proved that the SSRI exert not only a direct action on serotonin inhibition of a particular serotonin, but exert indirect effect on anxiety through the release of neurosteroids, in particular allopregnanolone. So the neurosteroid could be the final effector of the positive effect of SSRI on premenstrual syndrome. The same we can say for in menopause and premenopause. We know that the deficiency first in premenopause of progesterone and then also of estrogen and the testosterone create an impressive dampening of neurotransmission production, because progesterone is an activator of GABA. Estrogen is the perfect antidepressant because activates serotonin, endorphin, and also dopamine. And testosterone is the strongest dopamine activator. So it's clear that depression and or insomnia or mood disorder in general, anxiety, of course also top flash, but this is typical of menopause. These psychological disorders improve very well in an impressive way without using drugs. But you know that a lot of SSRI often are used in treating menopause disorders. I think that we can do this in women that cannot take hormones, but it's crazy to use psychodrugs for treating mood disorders that are closely related to hormonal imbalancement.
Yes. Did you know also that SSRIs, those antidepressants, also increase quite clearly the testosterone in women and in men? So that's one of the other effects why they work. But so what is your opinion? If you have a person who's depressed, would you give first hormones or would you give first antidepressant drugs?
This is a smart question. I think you have a very young brain to do this question. Great.
Well, you know probably my answer, but I want to know your answer.
It's clear that if we check the hormones, we check the hormone in some disease like that are classically related to hormonal imbalancement or hormonal deficiencies like postpartum depression, for example. This is another interesting disease that a lot of women know very well. And premenstrual syndrome, menopause, and for men in andropause would be great before to test the level of hormones, but it's normal, and to treat first the compliance with hormones. In a second step, we can use also antidepressants. Depends also the severity of the disease, because we have a mix of factors in the promotion of depression. Depression is not a normal aspect. Depression is related to stress, is related to environmental situations like if we think to lockdown of these 2 years. So depression is a multi-faced disease. But in this typical situation, we have a great improvement of the compliance using the perfect mix of hormones. This is for women and also for women, also for men. In andropause, we have a great improvement using testosterone, using a combination of DHEA and pregnenolone. In men, we have an improvement of the self-esteem. We have an improvement of well-being. We have an improvement of sexual arousal, and without using drugs. I think that in this situation, it's better to start with hormones. If we don't see great results, we can switch to drugs. But the most doctors do the contrary.
Yeah. So are there many doctors like you working in Italy with hormone therapies, or a few?
Sorry, but
are there many doctors in Italy working in the hormone therapies, or
in
just
Italy,
a few? Yeah, in Italy. How's the situation?
You are speaking in Italy?
Yeah, Italy. What is the situation?
Yes,
if a patient in Italy wants to go to a doctor, will he find easy a doctor?
Sorry, but in this moment, your voice looks like a Marciano, an UFO.
Oh, you don't hear me well.
In Italy, we don't have a lot of doctors because we don't have too many schools. But I think 150, not more, of doctors use hormones in anti-aging. Mainly, of course, are gynecologists. A lot of gynecologists are using now bioidentical hormones and testosterone, especially through vaginal route, and especially DHEA. This is in Italy. This is the specialization that uses hormones, also bioidentical, and we have a progress in the use of hormones in this area, thanks to the School of Endocrinology, Gynecology, Endocrinology of Professor Genazzani. They are very focused in the use of bioidentical hormones in this area. Less in other specialization, much less. But I think that it's growing. It's growing.
Okay, good. I think we're finished now, Ascanio, because you have to leave. It's almost 8:30, so I don't want to put you on the stress. I really thank you for being there. You have given a bit the energy from Italy. Very good. Thank you, and I hope that you will continue with your work on neurosteroids and hormogenesis and all those things. Thank you. See you.
Thank you, Thierry. Thank you. Bye bye. Bye bye.
Bye-bye.
Have you
Don't forget to take out your video.
have you
Thank
great
you.
show. Bye bye. Bye bye.
Thank you. Thank you. If you can take out your video now and on release, okay, good and perfect. Okay, let me now take full control. And I'm going to talk about actually my experience with psychological disorders and psychiatry. And I must tell you, it's not a real secret, but I have started medicine actually as a psychiatrist. I started as an assistant in psychiatry. And when I saw so many hormone deficiencies among the people with psychiatric diseases, I must say that I said I'm not in the right place in an institute of psychiatry. I think I have to go into endocrinology, which is a family tradition since about 4 generations from father to son. And I have also a sister who works in endocrinology. So basically, I had more success with hormone therapies to treat psychological disorders, much more than the psychotropic drugs that often decrease the hormones. So this is I would say a very special overview seminar of a model on psychological disorders and psychiatric disorders and the beneficial effects of hormone therapy that is very close to my heart, because I'm really fascinated about solving actually depression, anxiety, autism, and paranoia, schizophrenia, and all those different disorders. So let me show you some of the slides. So basically, the model I have constituted for physicians is a model on a whole session of 2 hours on anxiety and hormone treatments. Then there's 2 talks about 2 hours, 2 hours and a half on depression, with all the main hormones that you see here that really work, with a lot of studies, but a lot of practical information, exactly what you should be careful when you have such a problem. So the stress, also disorders, distress actually, the hormone treatments are probably most efficient working is to resist the stress much better when you're on the hormone therapy. But there are different stores of stress disorders, so that is investigated. We'll have a talk on autism and schizophrenia, very in detail. There's a lot of information. It's actually 2 talks, one on autism and one on schizophrenia, with always the practical tips, how to do it, how quick people will improve and things like that. You have all the information. And then there's a session on patient cases, and there are other sessions that will be later added on nutritional and nutrition and lifestyle and diet to improve actually mood disorders and psychiatric disorders. So let me give you some of the information I give. And for example, in the first session on anxiety disorders, we will see that there's a frequency considered 4%, but that's 4% of people have a severe form of anxiety disorder. But all of us, including me, we probably have some minor forms of anxiety that are worth to be treated by hormone therapy. For example, if I stop for 2 days my growth hormone treatment, I start having little anxiety all over the time. I'm not very anxious now, so of course I'm taking growth hormone. But so every hormone can help you, or many of those hormones can help you to decrease anxiety much better than drugs. Benzodiazepines have also been linked to higher mortality, more cancer, more Alzheimer's. So that sort of calming pill doesn't have side effects that you don't have with the hormones if you give the adequate amount. And so in Western Europe and North America, there are a lot of people suffer from anxiety. So in the countries that are richer, I would say, it's more anxiety. And in the European Union, more than 60 million people have anxiety disorder. So it's really something that is worth doing. But those 60 million that we're talking about, European Union, that's just the top of the iceberg. And we know what happened with the COVID. There's so many more people anxious. And what happened with the Ukraine war, especially in Europe, there's more people being anxious. We feel also the anxiety of the Ukrainian people. And so we're really supporting them, but on a distance, which is maybe not as efficient. And so to give an idea how important it is to treat anxiety disorders, because the severe anxiety disorder, that is then a psychiatric disorder actually, is linked to 5 times more suicide death in women before the age of 45 and 7 times more suicide death in men. So something has to be done about, and giving just drugs that treat the consequence and not the cause of an anxiety disorder, because hormone deficiencies can be cause of anxiety disorder. Well, treating only the consequences maybe not that satisfying for a physician. And so what are the 5 major hormone deficiencies behind anxiety? Well, important anxiety, especially growth hormone and low IGF-1, low growth hormone, that's probably that sort of deficiency gives the greatest anxiety. It gives a dramatic anxiety that goes into panic attacks easily. And low testosterone in men and women is probably the second deficiency to give important anxiety in both genders, not only in men. Oxytocin also, but low oxytocin is more an anxiety when you're in social interaction with people, when you meet people, when you're afraid of meeting people. That sort of anxiety can be overcome with oxytocin. So low oxytocin gives that sort of social anxiety. Low progesterone, we talked about the premenstrual syndrome with Dr. Ascanio Polimeni of Italy, and progesterone has really a calming effect on the anxiety of the premenstrual syndrome, but it also has a calming effect in men. If men take it, they generally say that my shoulders and my neck are more relaxed when I take it, and I sleep better with it in a relaxed condition. And so then there's melatonin. Melatonin taken at night also decreases anxiety quite a lot. So these are the major hormone deficiencies that actually give anxiety, and when you give the treatment, you overcome anxiety quite well. So let's look at some of the information. Growth hormone supplementation on anxiety. Where is growth hormone produced? Well, growth hormone is produced in this tiny little gland that is called the pituitary gland, and in the anterior part, it is made. And this hormone, it can be supplemented, and it gives actually probably the strongest anxiolytic effect possible with a hormone therapy. And it really makes you calm and cool without losing your concentration like benzodiazepines do. You really are relaxed the body, and you see what is essential in your life. I even became much more spiritual when I started to take growth hormone, because I was free of those parasite anxiety that I had, and because I'm relaxed, I could see everything once more essential. And so it really helps me to make good decisions and just to feel good. That alone is already a major effect. And so it gives you deep inner peace, and it promotes spirituality more than any other hormone. I can talk to you a lot about spirituality, but I must say, I have to say thank you to this treatment, because it really helped me on see what really matters in life. And then we have what sort of typical anxiety do people have when they have growth hormone deficiency? And this sort of information I see for every hormone deficiencies, because I have the advantage of having also a lot of deficiencies. I have to correct myself, but also having those generous patients that come to me and that I help, and I see then the difference. So growth hormone, when you're low in growth hormone, you have compared to growth hormone sufficient adult, you have the impression that the world is a fearful place because you have the level of a dwarf, actually, of growth hormone if you're very severely deficient in growth hormone and in a big body. And so that gives a lot of anxious thoughts and feelings. And without any reason, you just feel anxious and you don't know why. That's typical for growth hormone deficiency. And so that gives you anxious thoughts that are and feelings that are during day and night. And you have a tendency then, if you're growth hormone deficient and you're not treated, to dramatize, dramatic. You find everything's dramatic and get outbursts of anxiety. But that's not very pleasant for your environment. Basically, if you're growth hormone deficient, you cannot do anything about it. You need to get a treatment. If you don't do that, then you're helpless against this dramatization. And so social phobia patients that are afraid of mixing with people. And basically what you see here is that they have a 23% lower growth hormone level after stimulation by clonidine. But panic disorder patients that have a more severe form of anxiety, they have a 61% decrease of serum growth hormone. So more than 2.5 times lower growth hormone levels. So no wonder that they have panics, attacks. And so also when I teach about growth hormone and I teach about anxiety disorders, I also give the tips that are important to do and to respect. You first must measure the most efficient product when there's a growth hormone deficiency, and that is growth hormone itself, the bioidentical growth hormone, not the growth hormone secretagogue, nor growth hormone peptide that is a fraction of the molecule. You need the real thing, the growth hormone. And it's more efficient to decrease anxiety. The second tip is that you don't need a lot to decrease anxiety. 0.05 milligrams to 0.1 milligram is often sufficient to decrease most of the anxiety and improve psychologically. So it's also better tolerated. You don't get adrenal inhibition, etc. So low doses are sufficient with growth hormone. And then you should absolutely avoid alcohol at least 5 days a week, if not more, because alcohol decreases by 70 to 75% the growth hormone you will make in the night, and also neutralizes the treatment. So it's almost not useful to take growth hormone if you drink every day 2 glasses of alcohol, for example. You will neutralize much of the efficacy. And so basically, very important to know all the little fine-tuning you should do when you have an anxiety disorder or depressive disorder. It's not always the same sort of tips you have, or you have autism, etc. Now, I wanted also to talk about testosterone supplementation in men and women who have anxiety. Of course, I'm talking about supplementing people who have hormone deficiencies. I'm not talking about giving a hormone treatment to a person who has no deficiency, because it will not work. Hormone therapies work to decrease anxiety and to improve psychological disorders if the person has low levels. They don't have to be catastrophically low, but they have to be inadequate levels, insufficient levels. So when you give testosterone to men, but also to women, they become determined. They know what they want. They know they can do this, and they will do it because they have the power to do it. So growth hormone gives them power and self-assurance. And so no wonder that improves depression in men. It also gives them courage, exactly what a person who has depression often is lacking. So testosterone can reverse that in men. And actually, testosterone is even more spectacular in women. So I've written a book for testosterone I think can really interest you, because it has all the information on prostate cancer, prostate hypertrophy, or you can reverse that or treat it also with testosterone and some other things. How to treat the testosterone deficient when it's mild or moderate or severe, how to correct imbalances when they make too much estrogens out of it. So you really have a lot of information in it. If you want a book that overviews all the literature with all the scientific references and mainly all the practical information and pictures, you have it in this book. So I really would give you, I would advise you to have this book. You really have the information. So let's look at women. When women have a testosterone deficiency, they have a mild to important anxiety during the day. They especially hesitate a lot. They cannot take decisions easily. Very difficult for them to take decisions when a woman is testosterone deficient. She also worries a lot. And there's a lack of courage and of daring. They don't dare to do things. And so there's a whole series of way of treating all these different type of anxieties that a woman can have with testosterone. And I can tell you, it's really efficient to make women impressively better for the anxiety with an adequate dose of testosterone. But there's a little tip, is that never give, as a physician, testosterone to a woman without giving female hormones. There must be a balance between the two. What about oxytocin supplementation on anxiety? Well, oxytocin is produced actually by the hypothalamus. And the hypothalamus actually provides oxytocin and is then released in the pituitary gland somewhere below, but it's made in the hypothalamus. And when a woman has anxiety due to oxytocin deficiency, but also it's the case for men, she is anxious or he is anxious, or that can be mildly or severe in social interactions. I know this well because if I don't have oxytocin, I'm more anxious in social interaction. I don't want to go to parties or have difficulty taking into contact. You would maybe be surprised, but yes, it is much more difficult. You're more afraid, and once I'm there, it's okay. But when I'm not there, I can have tendency to isolate myself if I don't take oxytocin. So you have a fear of encountering, of also showing emotions. People who have low oxytocin, they have an anxiety, but they also don't want to expose emotions. They don't even know their emotions often. So blocked are their emotions. It's called philophobia. And this anxiety in social interaction is really a fear of people. Typically makes people shy. I was a kid, very shy. I can tell you I'm not so shy anymore, so I can reassure you, but it's easier with oxytocin now. So also, you feel disturbed by other people. You don't want to meet people because they disturb you. You feel aggressed easily when you're low in oxytocin. And then you're much more lonely because you don't want to see people, you get lonely. And so it's a lonely anxiety with oxytocin. So it's really something you need to treat in your patients because we're here to work together. We're here to live together. We're here to love each other. And without oxytocin, it's much harder to do so. And so the loneliness of nothing. And to see how oxytocin can decrease anxiety, we know that when you put cold pain stress on the arm, for example, you put a cold pack on the arm, that's a little painful actually. And that creates anxiety in young adults. And when you give them before intranasal oxytocin, the anxiety 30 minutes after such a test is much less. So it's significantly decreased anxiety. You feel better, you feel less anxious. So even with cold pain, it's okay. So when you see the anxiety, and this is the pain session, you see with placebo, you somewhere help, but the oxytocin, it's much better. It's more significant. I wrote a book on oxytocin, and it's probably my favorite or one of my favorite books because I told also my story and a bit my family story with low oxytocin and how it changed my life actually for the better. Um, and for example, I who was a little bit shy or have difficulties meeting people, I wanted to buy a horse for my girl, my eldest daughter, and I went to buy, and we saw several horses, and I talked with everybody, which didn't happen to me very easily. With the people who were selling, the people who were there. I even talked with the horses much easier. I was not afraid of nothing socially. So it really was for me marvelous actually experience. I have good souvenirs about that. And so if you want this book, you can also download it. You can click on this and you will see how to get it. It's a book that is also good for general public, very easy to read, but a lot of information, how to do things, where it works, etc. I don't think there's another book like this with so much information on oxytocin. And so there's a session on other hormone deficiencies and their effect on anxiety. And these 5 other hormone deficiencies that can create anxiety are low thyroid, can be linked to anxiety, especially in the morning. More, you don't want to get out of the bed. You're afraid of getting out of the bed. That's typical for hypothyroidism. Low estrogens can also give a moderate form of anxiety. Low cortisol also too, because you don't have the punch to face things. Low DHEA, especially in women. And low pregnenolone are linked to more anxiety. And so I talk in this session a lot about all these hormone deficiencies. And let me just show you one thing. What about autoimmune thyroiditis? You've probably all heard about Hashimoto's disease of the thyroid. There's sort of inflammation of the thyroid gland where the body makes antibodies that actually destroys the thyroid gland. Well, this situation can sometimes be linked with so-called normal levels of hormones, but it's always linked with a lot of psychological disorders and physical disorders. So there's high cholesterol, more atherosclerosis in those people, more cancer also. But look at Hashimoto's thyroiditis and anxiety. There's more neuroticism. There's more obsessive compulsive disorder. And there's 9 times more panic attacks in people's Hashimoto's thyroiditis. So it's not an innocent disease. You need to treat it. And I have models that explain how to treat all thyroid dysfunctions, including Hashimoto's thyroiditis. You need to give supplements of nutrients. You need to improve the food. The supplements, nutrients is selenium, vitamin D, inositol, myoinositol, and you need to give thyroid hormones and much other things. You possibly need to give also adrenal hormones to decrease this autoimmune thyroiditis. Otherwise, the person, if a patient keeps on having this disease, has 9 times more panic attacks. Obsessive compulsive disorder means that the person is worrying all the time. How many people around you don't worry all the time? Maybe you also. So you probably might have an autoimmune thyroiditis, and you probably need to have a treatment so that your psychological disorder, if I can call that, gets better. And so also something is very important is that we live now in the COVID area, and too much thyroid can give also anxiety. And people who were before treated with thyroid hormones, some of those, since they had the COVID or had the vaccine of the COVID, they have developed a very bizarre form. They have they have anxiety, they feel nervous, irritable, aggressive, inner feeling of trembling, tachycardia. They actually developed thyroid overdose. And when you have that, you have to stop 2 days, and then you decrease the dose of thyroid hormone, because this is hypothyroidism. Strangely, these patients at the same time feel cold, have cold hands, cold feet, have slow Achilles reflex, which are consequences actually of hypothyroidism. So they have both hyper and hypothyroid. Hyperthyroidism in the head, the heart, the trunk, but extremities, they are hypothyroid. So how do you do it? Well, you need to compromise. And the compromise is taking less thyroid hormones. You have to get rid of the hypothyroidism because some of those patients I saw, they lost all their muscles. You get thin skin, for example, because they had too much thyroid that they were eaten up by that. And very bizarre, when you load the dose, they had warm extremities, felt better. But this is, since we have the COVID, there are much more hormone imbalances. There's often low cortisol, there's often low thyroid, but also more even often hypothyroidism. So doctors need to know that, and sometimes they have to compromise and take lower thyroid hormones so to avoid the symptoms of excess thyroid in their patients. Now, one of the reasons they get excessively thyroid is that they get excessively too much thyroid in moments of stress because they are cortisol deficient. So you correct the cortisol deficiency, you stabilize, there's not a too quick conversion of the weak T4 into the very potent thyroid hormone T3, and then it's okay. So you probably need to treat the cortisol deficient these patients first. So depressive disorders, what are the beneficial effects of hormone therapy? Well, there's also frequency following the World Health Organization is that it's very near that of anxiety disorders, although it's a little bit higher. There are 5% of adults suffer from depression, and older adults, 5.7%. So more frequent in older adults. And in the world, 200 million people are estimating having depression, but that's more a severe form of depression. How many of us don't have, from time to time, depressive feelings? There are more women are affected by depression than men, but still, when it's men, it's very painful. They seem to be not doing well at the job and to become jobless. So also the risk of suicide is even much higher than with anxiety disorders. Look at these figures. Women, 16 times more risk of suicide death before the age of 45 if they have depressive disorder. Imagine. When a person has a depression, it's in certain sense an emergency. 13 times more risk of suicide deaths before age of 45 in men. That's 2 to 3 times more than with anxiety disorders. And depressive disorders also gives more disease, like more abdominal obesity, more breast cancer, about 3 times more breast cancer in depressed women. And overall mortality is almost doubled after 1 year in depressed patients. They die from other causes than just suicide. And so we could really question of the fact that is depressive disorder not due to hormone deficiency or aggravated by hormone deficiency? It certainly is. I can tell you. Out of experience, I have much more experience as a doctor prescribing hormones to treat depression than a psychiatric institute with all those psychotropic drugs. And I'm not against psychiatrists. Some of my best friends are psychiatrists, and they do their best. They are generous people. They're really good people. But I think they should learn more about hormones, because with hormones that have better efficacy, there's an antidepressant. And you will see that their psychotherapy works better. I had once a psychiatrist that I didn't know. He sent me 34 patients, he said. And I didn't know. And he said, I sent you 34 patients and they all got better. And those 34 patients were my worst patients. The patients I had refractory depression or refractory psychiatric, and you all helped them to do better. That was amazing. So at least 5 symptoms of the 9 must be present. These are the criteria of the American Psychiatric Association. And you need to have a depressive mood, or loss of interest or pleasure, an increase or decrease in weight, sleeping too much or less, being agitated, or tired, or feeling guilty or worthless, or having reduced capacity to think it over and having thoughts of dying or suicide. When you look at all those symptoms that can characterize depression, you find them all as symptoms of hormone deficiencies, typical symptoms of hormone deficiency. So I really believe, out of experience with hormone treatments, that the first treatment of depression, but also of other psychiatric disorders, should be hormone treatment. It is not enough for all patients. For some it is really enough and makes a major breakthrough. Some need is so multifactorial that all the factors have to be treated. But an essential factor in order to have success is treating the hormone deficiencies behind the psychological disorder. So to see all the glands that help and make hormones against depression, the thyroid gland, and all these hormones are low often in various types of depression, estradiol, low testosterone. High estradiol can also give depression in men. Low cortisol, low DHEA, pituitary gland, low growth hormone, and low oxytocin. They all can provide, all these deficiencies can provide depression, and that is refractory actually to antidepressant treatment because it's caused by the hormone deficiencies. And so what is the best treatment for depression? Is it non-bioidentical antidepressants? I wouldn't say so. You can use them for a short time, but lifelong, no. Lifelong hormone therapies, yes. So bioidentical hormones, in my experience, work better. And it's efficient, it's safer, you don't have side effects if you give the correct dose, and it treats the cause of many of those depressions. So let's look at thyroid, what thyroid does for depression. Here's a hypothyroid patient, typically with swollen face, swollen lower eyelids, and doesn't look happy. And typically, if she is in hypothyroid, she will have depression, and she wakes up with the diet at the morning. She wants to stay in her bed because the world looks, let's say, makes her anxious and not want to get out of the bed. Also, typically, a person with low thyroid is in the morning not in a good mood, grumpy, upon awake, irritable, having a heavy head, because the head is really heavy. It's full of myxedema accumulated during the night. She also feels worse in the morning and at inactivity and at rest. So she feels better when moving, actually, and feels better in the evening and activity typically. So those patients don't feel bad all the time. They feel worse in the morning, and as measured as the more they move, the better they feel. And in the evening, often they feel good and don't want to go to bed because they have that good feeling. And for example, here, what is the depression rate of women with subclinical hypothyroidism? So subclinical hypothyroidism means that a patient has a high TSH above the upper reference range, and the rest in the lab test looks normal. Well, the risk of is about 3 times higher. Autoimmune thyroiditis, when you have antibodies against the thyroid, is 3 times higher. And when the overt hypothyroidism is also low thyroid hormones, below the lower reference range, limit of the reference range, 8 times more clinical depression in clinical hypothyroidism. So it's very frequent depression when there's thyroid dysfunction. And in Hashimoto's thyroiditis, with those antibodies, there's 1.5 to 9 times more depression, depending on the study. And there's and the severity of the hypothyroidism, and 40% more death by suicide. So it's not a healthy situation. So the mechanisms that lead to depression in hypothyroidism, there's a lot of mechanisms. And one of those mechanisms is just simple. There's an accumulation in the head of waste products called myxedema. You see how swollen this patient is? It's also swollen inside, around in the brain, in all other tissues. So this myxedema compresses the brain tissue. You cannot feel good when there's compression in your head. And thyroxine T4 alone treatment doesn't work well, because this study I did on patients who were on T4, and I later put them on T3 and T4 combination. But 60% of those patients taking thyroxine at the dose that was normally should have helped were still depressed. And so a second mechanism is that thyroid hormone are the most potent hormone to accelerate the blood flow through the brain. So in hypothyroidism, a decrease in brain blood flow. And this can be, in this study of Scheinberg, in 1950, very old study, 38% decrease in brain blood flow. And there was also more cerebrovascular resistance. And there was 27% less oxygen and glucose consumption compared to normal. So you don't have a good blood supply, don't have enough oxygen in the brain. And so what can thyroid hormone treatment do for depression? Well, in patients with Hashimoto thyroiditis, and you see here that patients with autoimmune thyroiditis, if they receive thyroxine treatment for more than a year, which is not the most efficient treatment, but anyway, compared to patients who didn't receive T4, there was actually 1/3 less risk of depression in the patients who received thyroxine. So these have normally, patients have normal values of T3 and T4 and TSH, but they had autoimmune antibodies that were damaging their thyroid gland. And the result is, if they are treated with thyroxine, they are better, less risk of depression. And what can thyroid treatment do for refractory depression? So what is refractory depression? That's a depression that doesn't respond to the traditional antidepressants. Well, those patients with this form of resistant refractory depression, and this is from a meta-analysis of 6 studies, they have actually 1.6 to 3.4 times more subclinical hypothyroidism, so have some degree of low thyroid function. And patients with antidepressant treatment resistant depression actually have 10 times more subclinical hypothyroidism, so 52% of these patients, compared to what was expected, 5% in general population, 52% had subclinical hypothyroidism. It means that the TSH is above the upper reference range, so that's already a degree of hypothyroidism. So there are studies that show the efficacy of thyroid hormone on refractory depression, and these are all placebo-controlled trials I'm showing, so there are more studies, and it shows that actually when you give T3 plus antidepressant, T3 is the most potent thyroid hormone, you significantly decrease depression in those refractory depressions. And so you have a whole series of studies where it worked, and those are the most valuable studies. There are double-blind placebo-controlled trials. There's even one here of 2013, so it's not all older studies. Some are new, are relatively recent. So now the second most potent treatment against depression is actually estrogens together with progesterone. I never give estrogens alone in women, even if they have a hysterectomy, always with progesterone. And so it helps for depression very potently in women who are estrogen deficient, not if they have enough estrogen. And so I consider this as the second most efficient treatment against hormone treatment against depression. And for example, you see this woman, in estrogen deficiency, women have 2 to 3.5 times easier depression in this 2015 study. And here's 18% of euthyroid women have depression, in this study at least, and 56% of young middle-aged hypothyroid women have depression. But an older person, if they have some form of hypothyroidism, it's worse. So there's more depression. 75% of older hypothyroid women have episodes of major depression, not the small depression, major depression. So hypothyroidism in general, you have to consider 3 to 4 times easier depression. We saw other study where in overt hypothyroidism, it was 8 times higher. Yeah, so this is a slide that should be in the thyroid function. So let's look at estrogen therapy. And one of the most amazing therapies is the efficacy of estrogen therapy to decrease postnatal depression. You see that postpartum depression, 70% of women in postpartum have postpartum depression. So that's quite high. So 1 on 6 women have postpartum depression. And it increases above the age of 35, almost doubles. And there's, if you have a high university degree, you're also almost 3 times more risk than people with lower education. And so postnatal depression, what is that exact? That's the depression in the 6 months after delivery, in the postnatal periods, in the postpartum, so in the 6 months after delivery of the baby. The main cause, in my experience, is insufficient estrogen levels during the postnatal period. So when you hear deficiency, you hear there's a treatment. And so what happens is, this gives an overview of actually what happens before pregnancy. You have a normal menstrual cycle with normal estrogen levels. This is the level of estrogens. You see a peak, pre-ovulatory peak, and then you have higher levels in the second phase of the menstrual cycle. When you go into a pregnancy, you have much higher levels of estrogens and progesterone. So that's all fine. A lot of compounds fighting off depression. But at the delivery, there's a crash, as a severe drop in estrogens and progesterone levels. It's almost 0. And that can cause postpartum depression, of course. It's too big change in a woman. And so in postpartum depression, there is 2 times lower serum estradiol levels. Levels are already low in women in the postpartum, but it's almost 0, half of the level in women who are depressed. It's actually levels below the lower reference range of menopausal women here. And so there are also 2.5 times lower serum serotonin levels then. And the lower the serum estradiol levels are, the more there's postnatal depressive symptoms. So it's really a relationship. Undoubtedly, the cause of the postpartum depression is at least partially, if not totally, caused by low levels of estrogen. There are other studies showing the relationship and also the improvement when you give estradiol treatment of postnatal depression. So here's a treatment with transdermal estradiol and oral dydrogesterone, that's Testosterone. And you see here 3 months of transdermal and then 3 months of cyclical dydrogesterone. And you see it decreased about 40% the depression scores on the Edinburgh postnatal depression. And then testosterone treatment. Let's look at another type of treatment. Testosterone treatment for women with refractory depression. You've done all your best as a physician and you have no success. woman stays depressed. You give hormones, you give everything, but you forgot to give high dose of testosterone. And those women remain collapsed. With small doses of testosterone, remain collapsed. With female hormones, remain collapsed. And they are no good to do anything. Extreme depression that responds to nothing, a real mental collapse. Some women have had that. Age 40, something happened or nothing happened, but they felt no energy anymore and they dropped severely. And you give treatment, they still feel tired and depressed. Nothing can be done about it. 5 to 20 years of collapse. And you as a physician or the magician, you can change that situation. You can change that by providing testosterone injections. 1 per month. During 2 to 4 months, you can have a drastically make without this collapse. One woman could become prime minister. An Iron lady like we've known in UK. Fighting spirit, she gets with it. I'm really amazed how this treatment can help women to become brilliant women. A woman should always become brilliant. That's her destiny. For men too, but I must say it's also the destiny of women. Women don't take their destiny. They're just a shadow of themselves. Woman, you need to shine with who you are. And testosterone can help women who don't do that without them, the testosterone. So you can give intramuscular injections, and there are those you can even give it every 2 days, but in general it's once a day, once per month, 50 to maximum 150 milligrams per month. Frequency once per month is generally, but it can be in smaller amounts quicker. But you need to avoid masculinization because with these levels you go higher, at higher levels. So you can give finasteride, and that's an oral progesterone derivative that blocks conversion of the safe testosterone into the dihydrotestosterone that provides masculinization, facial hair, hair loss, and things like that. So you don't want to do that in your patient. But the dose can be relatively high if you give high dose of this. But it always works well if you are able to balance well the finasteride correctly, and you don't have problems with the finasteride that you can have if you only give finasteride alone. You may never give finasteride without testosterone, also not in men. Otherwise, there can be some gentle regression. So DHEA treatment, can that help against depression? This is the double-blind placebo-controlled trial, where men and women with dysthenia. So dysthenia is actually a mild degree of depression. It's not severe, and it can be quickly improved if there's a positive event happening. So it's not constantly low in these persons. But you can have this sort of dysthenia, this low mood, and placebo 20% can be improved in this study. Those who took DHEA for 6 weeks, and the first 3 weeks they received 90 milligrams, that was investigated. After 3 weeks of 90 milligrams per day of DHEA, there was a 60% of patients improved. Symptoms that most significantly improved were the lack of feelings, the sort of emotional numbness, the loss of energy, the lack of motivation, all improved with 90 milligrams DHEA. DHEA is a slow working substance, but if you give a high amount, you have a quicker effect. You can have within 3 weeks much more effect, because 90 milligrams is an overdose normally. And inability to cope also improved. They were less sad and were less also with that 90 milligrams of DHEA. So it significantly improved depressive feelings. Now let's look at stress disorder. We made a survey among all our patients years ago. What is your major complaint? And they could list 5 complaints. The major complaints was fatigue, where they came from. That was the reason why they came to consult here. It wasn't the aesthetics. The second complaint was low resistance to stress. And we didn't suggest the psychological, we just let them write down what they wanted. Just ask them to make it short. So, and the third was depression. So imagine psychological course top head are really top of the concerns of patients coming to the consultation for hormone therapy. What is distress? Distress is an excessive stress that is not the positive stress we're talking with Dr. Ascanio Polimeni. That you need short positive stress to improve and live long. Well, distress increases mortality. If you have here patient with post-traumatic stress disorder, they had a heart transplant and they have a sort of developed a post-traumatic stress disorder. Well, if they had that after transplant, they had 14 times more mortality. Imagine 3 years after heart transplantation. So people who can have a post-traumatic stress disorder don't benefit much from their transplanted heart. And hormone deficiencies can increase stressful feelings and likelihood of post-traumatic stress disorder. So when we look here at the hormone deficiency that can make you also irritable, it's one of the consequences of being stressed by too much stress. Cortisol deficiency, number one hormone. When you're deficient in that hormone, you're very likely to be irritable often. Growth hormone deficiency, 2. Lack of growth hormone is more irritability. Progesterone deficiency, it's also a hormone that only calms you down, don't have enough, get more irritable. Look at these women in premenstrual syndrome who are lacking progesterone. They're quite irritable. Often their husband has to run away as he sees, my wife has again her premenstrual syndrome. There are more killing happening in the premenstrual period. So be careful and as a physician, treat the progesterone deficiency. Melatonin deficiency. If you don't have enough, you can also be more irritable. And then there are excesses. Too much estrogen can make you irritable. Too much testosterone too makes you impatient. Cortisol excess can also make you irritable. And melatonin excess also, because of melatonin excess, can increase cortisol levels and then become irritable because of low cortisol levels. But the worst irritability by hormone excess, estrogen excess, that creates this nervousness and irritability of the premenstrual syndrome. Let's have a close look at what cortisol deficiency can do for those distress disorders. Typically, when there's cortisol deficiency, the patient feels overwhelmed by work and stress. Everything is too much. Any work, any stress is too much. When you hear that from your patient, you know the patient has likely cortisol deficiency. And you know what to do. You need to correct the cortisol deficiency with DHEA. We'll talk about this in the model more deeply. And so burnout, post-traumatic stress disorder is linked to low cortisol levels. You see a meta-analysis of what hydrocortisone can do for post-traumatic stress disorder. And hydrocortisone significantly decreases these post-traumatic stress disorder symptoms. And it also increased the incidence of post-traumatic stress disorder significantly by minus 15%. And it also works especially in prevention. If you have a surgery, for example, that can create a post-traumatic stress disorder, start at the surgery cortisol. Start before, even before the surgery. And then you will see there will be less likelihood of post-traumatic stress disorder. So cortisol treatment, when you give it during cardiac surgery, You have less need for norepinephrine, so less need to intervene by the anesthesiologist to save the life of the patient. And in intensive care, it shortens the duration they need to stay in the intensive care unit because they recover better. And during follow-up, there's less stress symptoms, typically due to the hydrocortisone, and there's a better quality of life. So really, hydrocortisone is something that decreases stress symptoms, and it's the hormone number one to do that. And if you want to know how to treat with hormones, I have the hormone handbook that really gives you the keys to safe hormone therapies, how to do it, and how to solve therapy problems. If you don't want to buy a smaller book or less expensive book, it's the patient hormone handbook. And you can order it here. I think if you work with hormone treatments, or if you're a patient, you buy the patient hormone bank, these are the most essential books you can buy because you have all the important information you need to know to be able to go through. Now, I have done talks about autism, very detailed. I won't go in detail here. We cannot do all the things. I think people were more concerned by anxiety and depression. If you want to have more information, just register for the model on psychological disorders. But here, let me give you some information. What hormone deficiencies may increase autism? Oxytocin deficiency, thyroid deficiency, cortisol deficiency. Oxytocin deficiency is probably the number one. In some cases, can even be solved by oxytocin alone. I don't think the best approach is just one hormone treatment. I believe several hormone treatments is the better approach to solve autism, and also good food and some psychotherapy. So low growth hormone, low melatonin also can favor autism, and one excess, testosterone excess, has been considered of increasing autism. This may be one of the reasons why boys are 4 times more affected by autism than girls. And just to know, just look at a boy, for example, who has autism. Look at him. What do you see? There's a lack of facial flush, lack of emotional expression, divergent eye gaze. He avoids to look into the eyes. He has swollen lower eyelids, no smile. Those are all physical signs of hormone deficiency. The lack of facial flush is lack of oxytocin, lack of emotional expression, lack of oxytocin. Divergent eye gaze, lack of oxytocin. Swollen lower eyelids, low thyroid. No smile is also lack of oxytocin. But there are more signs. So I look into details with pictures in the model. So let's look at oxytocin deficiency and autism. And you see here, for example, autistic boys compared to controlled boys, let's say healthy boys, have significantly lower serum oxytocin levels and also have high levels of the C-terminal extended peptides of oxytocin. So oxytocin is lower, but other forms of oxytocin, where it's linked to amino acids and less efficient, are higher in these to have unusable oxytocin levels. And so there's a greater ratio of those C-terminal extended peptides compared to the oxytocin. And that gives deficits in oxytocin peptide processing that they reflect. So they are not able to work well with oxytocin, these autistic boys. And when given oxytocin treatment, this is the case of Sarah, a girl of 3 years that was considered autistic. She wasn't, never spoke at 3 years when I got her first. Here she's at 5 years, hyperkinetic, no attention, affection given to the younger brother. Considered low IQ of 75. And the solution was to give her very small amounts of oxytocin, sublingual, 3 international units per day, 1/8 of a tablet of 10 units. and she was much better. When she came back here, she was very hyperkinetic, didn't look me into the eyes because she had stopped the treatment regularly. There was a sort of supply problem. They didn't have oxytocin enough. And then she came back into her autism. She was obviously diagnosed, and also her brother, as autistic. And then we had an official paper saying they were not autistic, but that when she, was they were taking both oxytocin. So also another deficiency can promote autism is cortisol. And I want to make you realize that it can start in the pregnancy. Mothers who have a low serum cortisol during the pregnancy have actually later in their 5-year-old born children, there were significantly more autism spectrum disorder symptoms among the boys, not the girls. So low cortisol level in the mother is not good during the pregnancy. A low cortisol level in the mother during the pregnancy also gives more vomiting, more nausea. So women with nausea often have cortisol deficiency. It gives also the melasma that they have on the face. So you can spot that. You don't even have to check the blood. You just look at the physical signs. You already have an idea if the patient has a low serum cortisol that can give to a child autistic, give a child more autism. And the treatment is then, of course, to give during, and it's safe, hydrocortisone, vitamin cortisol, with small dose of DHEA, not too much. What about schizophrenia? I also have an abundant information on that, how you can deal with it. And I think again here that hormone treatments are as important as psychotropic drugs to help this patient. I think they need some psychotropic drugs. The problem we have with schizophrenia is that these patients refuse the treatment. You can do fantastic treatments and they don't take it, or they take it a while and then throw it away when they're better. So it is real problem of their sort of opposing thoughts and action against any medical treatment, especially hormone treatment. So oxytocin deficiency is probably the most severe deficiency in schizophrenia. Growth hormone deficiency too. These are the two most important ones that contribute to schizophrenia or psychosis. Thyroid deficiency also can help, can promote this sort of schizophrenia. Cortisol, DHEA deficiency, melatonin deficiency, estrogen and progesterone deficiency. Progesterone in men, there's a suspicion there are 50% lower levels of progesterone in schizophrenia in men. And testosterone deficiency in men can also promote schizophrenia. And so the corresponding correction of these two deficiencies with the hormones help. Let's look at growth hormone deficiency. And when you look at a person with schizophrenia, like here, he's actually talking to a tree that is here. They have difficulties to prioritize. They have a lack of inner peace and anxieties. They have a bowed, tense back, typical of low growth hormone. They have a tense body during the day. And so when you look at chronic schizophrenic men that don't take any psychotropic drug, you see that compared to healthy men, they have significantly lower growth hormone levels at night between 10 p.m. and 8 a.m., so the whole night. The growth hormone is mainly secreted at night, and they don't really have a nocturnal growth hormone peak. And most of the growth hormone is secreted at night in form of a peak. More than 75% of growth hormone is thus produced, and that is absent in those men with schizophrenia. Can DHEA treatment help? Among all those treatments, well, here's DHEA treatment that was added to antipsychotic drugs, so as a adjuvant therapy, and decreased the negative symptoms. What are the negative symptoms? In schizophrenia, patients don't do some things, like they don't socialize. That's a negative symptom. So if there's a lowering of negative symptoms, that means that they're socializing, that they're doing activities they didn't do before. And also decrease the extrapyramidal symptoms. We know that you have those abnormal involuntary movements of hands and maybe other limbs due to the psychotropic medication. That is decreased by DHEA. And so I also have a section on psychological disorders where we see practical patient cases, very, very instructive model. And I think everything will be out this week or for Monday or Tuesday, next Tuesday latest. And let me give you some information about my next events before we go to questions. Is that on Saturday in the United States, through webinar in a conference of HRT, Bioidentical Hormone Replacement Therapy Conference of the IFRM in San Diego, I'm giving at 1 p.m. Pacific time, a conference of 2 hours. I think it's really fascinating on how hormone treatments improve the physical appearance and physical signs of hormone deficiency. And in July, I will do for Access Lab a live webinar. In August, for Pharmacia, will be this Congress in Buenos Aires for the Pharmacia VIP Congress, also live webinar. And in September, I will give a webinar for the A4M on longevity. I will give talk in a conference live in Madrid in end September, beginning of October, with also a little workshop. So also longevity, reversing physical aging, detecting physical aging of hormone deficiency. And then there will be also in October another longevity webinar where we'll have probably a very prominent person in longevity talking. And we'll also have in November Longevidade Congress, Sao Paulo, Brazil. That will be very interesting. Also a whole workshop on longevity and also a workshop on longevity at A4M Congress in December. So very exciting information. A lot is around longevity. There's new information. There's fascinating information of what hormone therapies can do. Also my medical education, we have this program, evidence-based postgraduate program that you should really subscribe. You have all the information how to treat COVID infections, on fatigue, on thyroid hormones, on cortisol, on the hormone consultation. If you really start in hormone therapy, you should really get this model of hormone consultation. You will see it's very practical, gives you all the good information you need to know to go through with a lot of pictures, very interesting. Etc. So there are a lot of, you can go over, you just go onto the website, get that information. But I especially say hormone consultation. If you're a beginner, even if you're advanced, there's a lot of information you never knew that is in here that helps you. This is the model I'm presenting here, psychological psychiatric disorder. And we have 5 models that are available in Spanish. And I really thank Jennifer. Jennifer is doing all the work of translation. She's really great. And she did a fantastic job. So in Espanol, it is also. You have a special offer if you buy these books here. That's the book on Oxytocin. That's the book on testosterone therapy for gentlemen. And that's also the atlas with a lot of pictures on physical science, more than 650 pictures of hormone deficiency and hormone excesses. Really, really, if you want to purchase, just click here. And want to thank all these partners that has helped us, Access Lab, Laboratory Knee Limbs, Longevidade Sadovel, Forthouse Apotheke, University Compounding Pharmacy, and I'm missing some of those, Townsend later, and they all are really doing great work. And then I want to let Energetica Natura present themselves, but I'm closing the music. I will give some commentators on this so that we can do it. So Energetic Ganatura is one of the best partners I had up to here. And they are very reliable distributors. They work through whole Europe, especially Western Europe. And they have done a fantastic job. I'm trying to see if I can put the music a bit lower or stopping it. Because they are really doing some of the best products I know. And they are doing also some short congresses that are really interesting for doctors, etc. So the high quality products, they're also friendly people. These are the countries they're really active. They're more than 30 years. They're actually did a whole party about that. And so they're really people who work in, I would say, Western Europe. I really recommend this firm. I'm very grateful. They always have helped us. They're positive people like you want. They have a whole academy of trained physicians in all the nutrients and etc. So you have a reliable partner who doesn't want to sell you just a bad product, just want to sell you the best products. And I'm always happy to present them and to give them the opportunity to present them here on this webinar. Now, next slide then. These are all the social networks where you can follow me and the work we do. I work also with other physicians that are, I'm very grateful to be able to work. You have the YouTube where there's a lot of conferences, short interviews or longer interviews on, and not only on me, there are other doctors also interviewed that are very, very interesting, Facebook, etc. And if you want to contact more personally, office@hertoghe.eu is the email, and that's where you can buy books, training programs, the hertoghemedicalschool.eu. So please contact us. Now we're going to the questions, and I'm going to stop sharing my screen. So you will see me, and I have here a list of question and answer that I will answer. And we cannot stay too long because the interpreters, so we have about 20 minutes. Okay, somebody's not understanding English, but there's a French and traduction française. Okay, question and answer. What is the right value of progesterone in plasma for men and for women? Well, the right value in women depends if she's before the menopause, she has a menstrual cycle, you check the progesterone the 21st day of a 28-day cycle. So about 7 days, 1 week before the menstruation, you have a peak level of progesterone, and that level should be between 8 and 18 nanograms per milliliter. Sometimes lower values are accepted. Ideal would be around 13, 15 nanograms per milliliter. In men, it's about 1 nanogram per milliliter, not more. And in men, the progesterone is made by the adrenal glands mainly. Do you recommend the application of progesterone to treat benign prostate hypertrophy? Yes, I surely recommend that. You can give an oral form, like 100 milligrams of progesterone in the case of benign prostate hypertrophy, but also I give suppositories of progesterone, like 100 milligrams suppositories of 100 milligrams progesterone suppository, and I can add ethiol 300 milligrams, which is sort of antiseptic preparation that also is helpful to decrease benign prostate hypertrophy, because benign prostate hypertrophy is partially reversible, if not totally. What are the signs of progesterone or pregnenolone overtreatment in men? In men, when you give progesterone, you give too much progesterone, they can have aldosterone deficiency symptoms. They have low blood pressure because progesterone can block aldosterone receptors, can low blood pressure and a dizziness in the head. And they can also be more depressed because it decreases estradiol levels sometimes too much. So you can have some sort of depression and lightheadedness. So you never take, really never take progesterone, oral progesterone as a man in the morning, because then you would have this heavy head that you can have. With pregnenolone, the only side effects I had when I tried it was at 300 milligrams, which is a huge dose, was actually an oily skin, so it converted too much in androgens, testosterone, and my skin got more oily. So that was the only sign. Otherwise, pregnenolone doesn't have too much easy overdose signs, because the normal dose that you give a pregnenolone in the morning, first thing, is 50 to 100 milligrams. So with that, you generally don't have any physical sign of overdose or psychological sign. You just have a better short-term memory. That's all. So don't forget that when pregnenolone is given, always provide the first thing in the morning, because then it starts working for the day and you'll have a better short-term memory for the day. Then the question here, do you have any question from Melanie? Do you have any recommendations for hormone treatment of an intellectually impaired mental age, about 18 months, 37-year-old woman who only attacks people premenstrually? Yeah, well, if she attacks one premenstrually, you provide progesterone from the 15 to 20, from the 16 to 26th day of the menstrual cycle. She has normal cycle, provide about something like 12 days of progesterone in the evening, and she will be much more friendly. Now, how can you improve? And I cannot make a promise, but that's what I would try. I would also try to improve her intellectual properties. Unfortunately, if she has at age 37, the mental age of about 18 months, you won't be able to improve to an adult age because of the damage done. But basically, I would give thyroid hormones and I would give growth hormone or IGF-1, and she will probably have age 7 or age 10 year probably if you have the money to pay her treatment. Then Frank here space, speaking about intermittent fasting, how many hours, for example, 16 hours, and how many times a week? Intermittent fasting is you don't eat during a certain time, and that gives a rest to your body and to your intestines, and makes you that you can have less disease, less cancer, less heart disease, lower cholesterol, less obesity, and also live longer. In animals, they can live longer with intermittent fasting than they can live with a low-calorie diet. With a low-calorie diet, you live about 20% longer duration of mice. In my studies, it is 35% longer when there's intermittent fasting. So it's important to do it well. And basically, the animal studies have been done differently than humans. The animals are fasted 2 days per week, no eating, and then they can eat what they want the other days. So in humans, what we do is you eat 2 meals and not 3 meals a day. And they should be close enough to each other. So you have 16 hours fast. So you eat, for example, in the morning, and you eat in lunch, and maybe 2 hours later, but not later, not more than that. So you have 16 hours of fasting in 8 hours where you can eat. That's what you can do. So basically, it's easier to remind that you just do 2 meals a day, and that they should be follow each other. More or maybe a snack more can be taken, but there should be 1 meal that you don't take, and that's the best way to do it. You can of course do a whole day of fasting. I do actually I eat 1 meal a day 2 days a week when I can, and that helps me to recover from the 2 days. I sometimes eat 3 meals, but on the average I eat 2 meals. And that's a good form of intermittent fasting. The treatment of ID 37-year-old with premenstrual, so she seems to be polar also. So do I want to use S? And I do not want. What can you do for bipolar disorder? Bipolar disorder, that's a disorder where you have a manic phase where they're very nervous and euphoric and very agitated, and then you have a depressive phase where they're not doing much and they are sad and feel bad. that is the hormone deficiency behind there that is mostly low thyroid function, especially what is called the rapid cycling bipolar disorder, where you, more than 5 times per year and up to 50 times a year, you have ups and downs of the mood. And that responds well to thyroid therapy. And there's a lot of thyroid deficiency, like 10 times more thyroid deficiencies in people with bipolar disorder. So you should provide thyroid hormones. And I think it's the same woman that we're talking about with a low IQ. I think the thyroid hormones will really improve that and make more regular her mood. What supplements do you use that modulate serotonin? Actually, I don't focus so much on serotonin. I focus on hormones that improve depression. But for example, thyroid hormones increase serotonin levels. But if serotonin levels are too high, and some people it's too high, they decrease the serotonin level. There are also studies showing that, a Russian study. So basically, I provide a precursor of serotonin called 5-hydroxytryptophan. That's the immediate precursor to serotonin. I provide that for 2 reasons. The 5-HTP, either to decrease appetite. So I give, for example, not more than 25 milligrams in the morning and 12.5 milligrams at lunch and 12 milligrams in the afternoon to decrease appetite. Or I give it at night to sleep better. I take myself regularly, not always. I change with tryptophan. I use 5-HTP before bedtime, and then converts in the night to serotonin, and then from serotonin to melatonin 4 hours later. So I can sleep the 4 last hours of the sleep better. And I give them 50 to 100 milligrams. Okay. We also saw that estrogens also improve serotonin levels. So you can really improve serotonin levels by hormones. There's a person asking if there's a replay. Yes, there's a replay. If you don't have to go away because you have some other things, you can always view this later on. And then Monica here says, can a psychotherapist heal depression and anxiety without balancing the hormones first? Or can therapy be eternal if hormones are not balanced? So if a psychotherapy is working with what is called refractory depression, refractory anxiety disorder, which it doesn't have, is because there's a hormone deficiency. So if you don't correct the hormone deficiency behind it, it doesn't, it's not helpful. You need to combine the best, and the best is psychotherapy, certainly, and certainly also in current or chronic psychological disorder, also hormone therapy. That's in my experience. There's also something that is a little different from psychotherapy that I believe a lot in, is spirituality. We are here for a reason. The fact that I'm lecturing has some good effects, but it's not only, I get this information from others. So basically, I'm just sharing information I received. I'm sharing you the gifts I received. I'm not inventing everything. I'm just sharing. But some people don't improve, even with hormone therapy, because they have part of their soul that is not there. They're like, you can recognize those people. They are there and not there. They're absent. You have the impression that part of them is not there. And that is what's called loss of soul. And you can recover this by expressing emotions, by succeeding the spiritual experience. If you have a trauma, if you don't express the emotions that the trauma brings, you stick with the trauma all the time, and you stick with the blocked emotions. They don't leave you. An emotion only leaves you when you accept it and express it in yourself. It doesn't have to be expressed outside. So if you accept, I accept in all my cells, in all my molecules, in all my, etc. And I'm talking about also that spirituality in the model. And so any patient who blocks emotion will get sick of that. and it will give problems. And those who have anxiety disorders actually don't express enough anxiety on time. They don't accept anxiety. They're fighting against. Don't fight against. Use it as a force of transformation, a force that blocks your mind, that doesn't have to work all the time, and you transform. And after you are more sensitive, you can love more. So I would say psychotherapy, spiritual experience, successful run, and hormone treatments would be actually the three big things that make depression better. Otherwise, if you don't treat the hormone deficiency, and that was part of the question of Monica, you the consequences of hormone deficiency remain, and there will remain depressive feelings or anxiety feelings that cannot be solved by psychotherapy. I have a question about why is it that PMD patients can't stand progesterone after ovulation? So I suppose that it's not PMD, but PMS. Why do some premenstrual syndrome patients not tolerate progesterone after ovulation? Because they are too low in estrogen. So women who have ovaries that are weak and don't make enough estrogen and progesterone, they can have a premenstrual syndrome caused by lack of progesterone. When you give progesterone, progesterone decreases estradiol levels. The estradiol is more converted to the weaker estrone, and then they become estrogen deficient. Then they become, from first irritable, they become then depressed. Irritable because of lack of progesterone, and depressed because of lack of estrogen. Have you had success in treating bipolar disorder using hormone? And so what did you use? Well, again, for bipolar disorder, you generally always need to give thyroid hormones, but also to treat adrenal hormones, the deficient adrenal hormones, and then growth hormone really takes psychosis away, because bipolar disorder is sometimes considered a psychosis, so it really takes out the psychosis. And I would also give oxytocin. Now, the problem I have with patients with psychosis is that they refuse to take the treatment, or they take it a while and it goes better, and then they let it down. They are rebellant for a medical treatment. So basically, I have a hard time convincing, not the family, but the patient of taking the medication. So I would say there has been success in the past, but not often, and not because the treatments don't work with hormones, but because the patient refuses the treatment. But if you have a patient who accepts the treatment, you generally need to give thyroid hormones, hydrocortisone, and DHEA, plus growth hormone, and maybe oxytocin and melatonin, and then they are much better. My hands and feet are cold in winter. That's Jabber, who says that although I take thyroid hormone 60 milligrams a day in the morning before breakfast, my heartbeats are 90 times per minute, so I cannot increase thyroid hormone. Do you know why they are cold? Is it because vitamin D? I don't think it's because vitamin D deficiency that the feet are cold. I think that Jaber actually is not taking enough thyroid hormones, and it can tolerate it better by taking part in the morning and a little bit, an additional part just before supper, but also because that Jaber has probably adrenal deficiency, and then you don't tolerate thyroid hormones. You go quickly in tachycardia. So maybe there's adrenal deficiency in cortisol that slows down a bit the conversion of T4 T3, so there will be lower heartbeats. May be helpful in this patient. Now, why are the extremities cold? Also, some patients have accumulated quick mercury, and that accumulates in on the nerves, and so generally that can also give cold hands, cold feet. So you might have to do chelation therapy in these patients. Also, what also warms the hand much more is growth hormone. So if you give growth hormone, that stimulates the thyroid function, and then it also gives warm hands and feet, and extremities have more blood flow. Here, another question. Can you give progesterone to me? If so, how would you dose them? Well, but just test and you give also trial of treatment. I suppose that the person who anonymous is a man. Omar, is there a link between testosterone deficiency and neuropathic pain? Can testosterone supplementation help to protect nerves and reduce the pain? For neuropathic pain, it's usually also due to an inflammation. You need to have a whole complex of vitamin B, coenzyme Q10 helps a lot. And but testosterone can help against pain, but it's more muscular pain and ligamental pain. If you have Achilles tendon inflamed, it decreases that sort of inflammation perfectly. And it will also decrease neuropathic pain, but there are other treatments that might have a better effect, like IGF-1, for example, and cortisol. Cortisol balanced with DHEA. DHEA increases the anti-inflammatory effects of cortisol, so you should give it together, and then also protects against any adverse effects of cortisol. Do any hormones help to stop alcoholism? Yes, oxytocin is known to decrease substance abuse, including alcoholism, drug abuse, and things. So oxytocin is the number one. Progesterone also helps against alcoholism, and also treating the adrenal deficiency you have with cortisol. So I give a half tablet or a full tablet of not the bioidentical hormone in this case, synthetic derivatives, remains long in blood, like 2 to 4 milligrams of Medrol with DHEA, and that helps a lot against alcohol, taking alcohol. So here's anonymous. My mom's 86 and she takes Euthyrox. Euthyrox is L-thyroxine, despite from 75 micrograms to 100 micrograms, despite taking 25 milligrams of zinc and 200 micrograms of selenium. Her thyroid test shows severe hypothyroidism. So it's not, Euthyrox is insufficient. She probably needs to take desiccated thyroid like Perfothyroid or Armathyroid. If you give Euthyrox and you want to do it with T4, you have to suppress the TSH to have efficacy against F3. Free T3 is 2 picograms, so it's quite low, at the low borderline low, and free T4 is also average. Is there anything besides leotyronin to Estrogen to fix low T3? Any benefit in further increasing Euthyrox? So again, if you only have Euthyrox, you have to have high normal T4 levels in blood to have an acceptable T3 level in the mid-range, which is good. So you really need to decrease TSH to undetectable levels generally to have efficacy, of course, without any heartbeats. Can amenorrhea, that's a lack of menstruation, cause anxiety, depression, or vice versa? Amenorrhea is linked to a lack of estrogens. You don't have any blood loss. And of course, in lack of estrogens, there will be a permanent, all day anxiety and even more depression. So now, when you have depression for other reasons, like thyroid deficiency, then of course you will have weaker ovaries because of thyroid deficiency that causes depression. But anyway, when there's amenorrhea, there's certainly ovarian failure, and you will relieve the anxiety and depression by giving the female hormones, estrogens and progesterone. Here's a question in French, but I will translate into English. Can we, if I have possibilities for neurological diseases like those with the Lewy corpuscle? I don't really know what Lewy corpuscle is, but if it's the same as Alzheimer plaques that we have in the brain, or similar, or in the Parkinson plaques, Growth and IGF-1 are the best treatments against neurological diseases. So you need to have the subcutaneous injections of IGF-1 and growth hormone to have a reversal or a stop of the process. You can have all these hormone deficiencies. That's Marianne who gives that. You can have all these hormone deficiencies, but what I understand from Chinese medicine is that balance between yin and yang and their hormonal counterpart. Are there, for instance, optimal hormone ratios between all the hormones? There are optimal hormone ratios, not only between the hormones like estrogen and progesterone, but it's not like mathematics. You can check it by looking at the person. If one hormone is too high, the other too low, you can see that on the physical signs and symptoms. So you check it more with the patient. on the patient's complaints and the patient's physical signs, those balances between estrogen and progesterone, thyroid hormone and cortisol. And in my hormone handbook, I explain the balances that have to be respected in the beginning of the hormone handbook. That is really the basic guide and practical guide in hormone therapy. So yin and yang, you find it also in hormone medicine. How is the hormone handbook, the endocrine book, and other essential book different from testosterone book? Testosterone book has much more, like 15 times more information on whatever is related to testosterone and sex hormones than in the hormone handbook. So if you want to know everything on testosterone and really enrich yourself, testosterone book is by far the book. I don't think you have another book on testosterone that has so much useful and practical information and updated with the latest references. Would you dose estrogen and progesterone or progesterone in a postpartum depression woman? You want to continue breastfeeding, risk to the baby. So in my wife, after 1 month after delivery, I provided her female hormones during breastfeeding, and she each time breastfed during 2 years. So during 2 years after in the postpartum, she took female hormones while breastfeeding with no harm to the children. 2 pumps of estrogen, which is like 2.5, I think it's 1.5 milligrams of estradiol transdermal in the morning and in the evening from the first day to the 25th day of the month. Also 100 milligrams of progesterone, and there was no harm and was okay for breastfeeding. And it's better to do so because some women in the postpartum, because of their breastfeeding, have osteoporosis. And then because of the low female hormone levels, and you don't get that, of course. And the reason I gave to my wife was also because she was the director of a firm. She had a full-time job, and she had to direct her firm. So give her the energy to do so. And then I will ask, let's say maybe some more questions, but not too much more. How can you tell the difference between low cortisol and cortisol excess? Well, you have that information in the hormone handbook, but basically low cortisol is, for example, low energy, a hollow face, inflammation all over, and they're weak. In cortisol excess, the patient is more euphoric, too agitated, too much energy, is swollen in the face. So there are many differences, but those are basic ones. You're rather thin with low cortisol and rather thick and fatty and swollen with too much cortisol. I seem to have both hypothyroid and hypothyroid symptoms. When I start a low dose of desiccated thyroid, I feel much better, but also have hyper symptoms. Do you have any suggestions? Well, this patient called Alex, or this person, has low cortisol. And when you have low cortisol, you have a too quick conversion of the weak T4 to the potent T3. And so in stress conditions, there will be increase of low cortisol, and there will be hypothyroid symptoms in stress conditions, but in other conditions where there's no stress, the patient will be hypothyroid because there's not enough thyroid hormones. So this patient should spread the dose of thyroid hormones 2 times, bigger dose in the morning, a smaller dose for your supper, and take hydrocortisone and maybe other adrenal hormones like DHEA and maybe aldosterone. And that will normalize the situation. And that's a question in French. I'll translate in English. How can we diagnose bipolar disorder since 10 years? And I'm taking antidepressant treatment with a psychotrope. I have a lot of anxiety. This patient called Marie should, or this person should go and get hormone therapy. It will be much better than those drugs. And then the bipolar disorder will go. There's a lack of thyroid hormones. There's a lack of, certainly because of the very strong anxiety of a lack of growth hormone. and other hormones that calm down anxiety, but that has to be individually checked. Here's a question, I think it's from a person of Russia, of Ukraine. Would be very interesting to listen about the role of hormones in orthopedic pathology. Yes, hormones are very potent to reverse osteoporosis, to repair knee points, to reduce arthritis and osteoarthritis. So yes, it's very interesting, but it's another topic. Too much information to talk about now. So I will continue with some questions, but then we'll finish. What is the risk to administer too much progesterone in men? How can you evaluate if progesterone can help a man who does sports and is affected by anxiety? Well, typically a man who is affected by anxiety because of lack of progesterone has those tense shoulders in the evening. So if he takes progesterone in the evening, it won't impair his professional performance, and he can take 100 milligrams if there's a lot of anxiety in the evening. However, progesterone can also block testosterone, so you should not take progesterone before having sexual intercourse because it can decrease erection. So you take it after intercourse when you go to sleep, and then it's okay for a man, and generally without any problem. Can the use of progesterone in men increase the estradiol? No, it decreases estradiol. It stimulates the conversion of estradiol to estrone. And then let's say two more questions. Is hormone-dependent breast cancer treated by an aromatase inhibitor susceptible to get a prescription of DHEA testosterone to compensate for the lack of estrogen and progesterone by this medication? So this difficult question I cannot answer like this easy. It depends on the persons, but basically studies have shown that after breast cancer, if you provide female and male hormones, so estrogen, progesterone, and testosterone, you have a decrease in mortality, that's very important, and you have a decrease in recurrence by between 30 and 70%. Especially in hormone-dependent cancer, there's a decrease when they take estrogens of 70% of the recurrence of breast cancer. So it's rather good to give hormones, but still it has to be evaluated and per person. What are the hormones that help the memory at menopause? Well, of course, estrogens. There's 8 times more Alzheimer's disease in one Italian study in women who never took estrogens compared to women who were actually taking estrogens. So hurry on to the estrogens. There are many other hormones that improve. There's growth hormone, there's thyroid hormones, there's pregnenolone. So it's better you check this with a physician. And she rose here, or Karen here, for men who have gynecomastia who take testosterone, which can aromatase to estrogen, would progesterone cream applied topically help menopause? For gynecomastia, that's real milk glands in the breast of men. They have too much estradiol. They can put progesterone, but they mostly have to put dihydrotestosterone on the breast, and that helps to decrease the situation, and to take an aromatase inhibitor to decrease the estrogen. So they have also to stop the coffee and alcohol that increases the estrogens in the blood. Okay, I think I will stop here because we're out of time. Maybe just one question. What do you think causes thinning eyebrows? When do thinning eyebrows come back when you give thyroid therapy? So thinning eyebrows is typical sign here at the outer third of the eyebrow, lack of thyroid hormones. When you provide thyroid hormones in adult, they don't seem to come back unless you provide at the same time growth hormone. So growth hormone plus thyroid hormone makes your eyebrows terrific, I think. Inner eyebrow, the lack of inner eyebrow, that's due to lack of testosterone. There you need to correct testosterone. Okay, so voila. This is it. There's maybe one question because it looks like an emergency. I have a severe burnout with periods of anxiety and social phobia. Can I start DHEA alone to help me with my issues? At which dose? The problem of burnout is mostly a deficiency in cortisol. If you give DHEA, it can decrease cortisol. You better take cortisol with DHEA to get out of the burnout. That's the minimum to do. But the DHEA could lower the secretion of cortisol and aggravate the burnout. So it's not necessary. You can try, but it could aggravate the cases. And if you have social phobia and anxiety, you need other hormones, increase anxiety like oxytocin and other. So go to a physician, get a good treatment, and that's my advice. Thank you for being there. I must thank you. You were at 1,800 to subscribe. There were many questions and I think a lot of interest. And I really thank you for being there. It's warm hearting to have you. Bye-bye. Thank you.